just words for the morning. So Raffi, who's a good friend and been up here many times and an expert in many things, is going to give us an update on hereditary angioedema. Most of you were at dinner last night, and that was an excellent talk, but this will be free of any commercial constraints. So Raffi, thanks for coming.
You'll regret that applause. Thank you, Dr. Altman. Chime in as you have questions through the presentation. So I got asked to speak about angioedema, which is really broad. So I kind of honed it down to angioedema and then quickly dive into HAE, all right? Not sure what it's got. There we go. These are my disclosures. All right. We'll talk about angioedema just very briefly and then dive in to the hereditary type, looking at the challenges of recognizing it, treating it, and more recently, even integrating it into pediatric data, and then assess the impact it has, both as a disease and some of the treatments, and then review treatment options for it. And the word of the day, I'm actually going to change from prevention to, I gave my graduation speech at Morehouse, which is a historically Black medical school. And at the time, tolerance was the big word. And I don't like passive-aggressive terms. So the change is in the verbiage. I said, let's change tolerance and call it celebration of diversity and whatever term, insert your term. The formula needs to change in the way we think. So that's my little contribution to you today. So differential diagnosis, when you think of angioedema, drug-induced is probably the one that the fellows jump at, right? I got a 52-year-old African-American male, swollen lips, blah, blah, blah. Hereditary angioedema, come on back. Acquired angioedema, now you're starting to think in the complement world. And then idiopathic angioedema, where no one's really clear. And then you've got the allergic or pseudo-allergic one, which now is part of the protocol, and I'm not going into that too much, of ruling out histaminic or IgE-mediated swelling to then hone in on the even smaller zebra category. So right off the bat, where does angioedema hit us? A great majority of patients will have it in the neck, in the larynx. Little golden pearl. Drug-induced angioedema rarely is reported, and I mean ultra rarely, below the neck. So that's kind of a hint for when you're going on that consult, like, has had multiple throat attacks, and then this one's in the left hand. Ooh, got to start really thinking outside the box. Intubation for a good proportion of these patients, and then the edema can be in any portion of the body, essentially. Now, differentiating the two types, because you want to now split that angioedema into, are we having on the left hives and itching, or does the patient, and this is actually my patient, the youngest reported treated patient on demand years ago, or is it just purely swelling with no itching and no urticaria? And so let's step back and think 40,000 foot view, how HAE kind of came to be. So it was described in the 1800s, but we know that this mutation could not have been that early, so it's much older than that. A name was assigned to it a few years later. The complete clinical description done in the late 1800s, and then the mode of inheritance identified essentially about 100 years ago. And then it wasn't until 1963 that the biochemical basis was defined as insufficient C1 esterase inhibitor activity, and the gene being identified and cloned in the 80s. And it wasn't until 2003 that we figured out, and I told the group last night, HAE, board question, you got your answer, maybe 1 or 2 points. It's a disease defined by C1 esterase inhibitor deficiency or dysfunction, but really the swelling is due to bradykinin, which is the last step that activates that receptor, the type 2 receptor. Now, it's rare. but it's autosomal dominant. So you have 75% of a chance of getting that history from the patient to make it really easy when you're on a consult or in your clinic to think maybe not allergic angioedema, but hereditary. And it's characterized by intermittent, unpredictable bouts of non-pitting, non-urticarial, non-itchy swelling. All right, so if you could start thinking in those terms, you can start honing in on those patients. Prevalence, around 1 in 50,000. Last night we had a patient in the room, so it was 10%. 1 out of the 10 was an HAE patient. And then now you can actually expand for the younger ones. You may not understand this. For folks my age group, Minesweeper, one of the early. No, these guys are like, you are really old, man.
What are you talking about?
On the PCs, Minesweeper, you start like identifying where the little mines are, and it just opens up a whole new window. So that's what you got to do with HAE patients or families. Now, it's not linked to race, and I can proudly say I've seen pretty much every ethnicity and race represented in, like, from talks and patient programs, et cetera, and HAEA. The age of onset is variable. Some people might be completely quiet through their life, and you'll hear that from a patient saying, let's say a female patient in their 30s who says, I think it skipped for us because my dad's mom has it. Well, probably because your dad's volume was low or maybe completely off, but that Metallica condition is still there, right? That HAE. So women tend to be affected more severely or more frequently than men.
Hey, Raffi, I've always wondered, there are like hundreds of different mutations in this gene. So it's a very fragile gene. Doesn't seem like an evolutionary smart thing.
Mm-hmm.
Has anybody ever thought about it? Why?
The utility.
Huh?
The utility of it?
Yeah.
Yeah.
Does it have, you wouldn't think anything would be passed on in humankind if it didn't have some utility beyond
Correct.
causing a bad disease.
I mean, blood pressure regulation, etc., was postulated. But remember yesterday, another golden pearl, more academic for the fellows, is all this activity, these receptors are not on the arterial side, they're on the venous side. So we don't expect any of these patients to just go hypotensive on us with all that swelling. And it's also non-pitting. So I don't know the utility of it. You know, as we define the immunology better, and we're finding newer and newer pathways, actually, that some through the MASP or the mannose binding lectin pathway, actually going straight to the receptor and upregulating it. It's getting really interesting for something that, like, oh, another HAE talk. All right. Speaking of mutations, the chromosome 11 contains the area that has the C1 esterase inhibitor coding. And as I mentioned, the polymorphisms are aplenty, and we'll go through specific mutations in a second. But 25% of cases are spontaneous. So it's the de novo patient that can fool you when you're trying to work up angioedema. So it's the SERPING G1 actual mutate variant. And you've got the majority of them being deletions, duplications, and some missense variants. The rest could be nonsense, splice defects, etc. Now, what does C1 inhibitor do? It's almost a captain on the field, right? Thanks for the laser pointer, University of Washington. So here's C1 esterase inhibitor, almost like a checkpoint in various components of the contact system, where factor 12 activated is prevented from doing its own auto activation, auto loop. Over here, as the zymogen prekallikrein forms kallikrein, C1 inhibitor will help prevent from that kallikrein buildup the conversion of, or the cleaving off of, bradykinin from high molecular weight kininogen. That's where the HAE swelling occurs. All right, so HAE defined by C1 inhibitor problem, swelling defined by the receptor getting activated. It's also got effect on the fibrinolytic system, and what I mentioned earlier, the MASP pathway driving up or are actually churning down the rest of the complement system. Another interesting fact is, and not too discussed in the literature, a good chunk of HAE patients will have lupus-like syndromes and symptomatology. And I've got 2 patients that were referred from rheumatology to me with lupus, and the rheumatologist saying, this person's having swelling, it's in your pod. I'm like, we actually share that pod. It's called the complement system. So keep an eye out on that too. And then a gentleman, a researcher named Nussberger in Germany, actually did a very nice study on 2 patients, but using femtomolars of bradykinin to measure. So these aren't readily available. Looking at the site of edema, the local circulating bradykinin, because remember, things like Netherton syndrome, you're familiar with, bamboo hair, right? Like shout out terms. Those are tissue kallikreins, and our treatment on those won't touch Netherton. Here we're talking about circulating kallikreins, all right, in the blood. So he picks up bradykinin levels that are about 3 to 8-fold higher on the attack side, so on the swell side, compared to the non-swelling side, even though the non-swelling side is actually higher than the average range for bradykinin. Make sense? So this kind of clinched the fact that it's bradykinin that's causing the swelling. Now, say you're swelling, and you're swelling, and you're swelling. It's almost like Mr. Miyagi, another Karate Kid inference or reference, I should say. You try to get your patients to start recognizing their attacks earlier and earlier, and those are the prodromes. And a good chunk of patients will have a prodrome that they can identify. And the highest proportion there is unusual fatigue, or I call it just crashing. And it could be Friday evening for you, where you're ready for that weekend gala, something going on, or it could be Sunday night for you, where you've got an exam the next day, right? And it's just fatigue, unusual fatigue. But you'll see what is described as rash on arms and legs. I always tell patients, don't use the term rash, because the ER is there to do, you know, actuarian work and stats. They're going to think, oh, rash. I was told non-HE, non-urticarial HAE, you know, angioedema is HAE. So it's actually erythema marginatum. Okay, so a serpiginous rash that looks like the leukoid rash, or hypovascular filling out of the skin. So following that, muscle aches, upset stomach, and nausea, usually those herald an abdominal attack. Joint pain, specify, is it inside your joints, or is it just that your articulation is tighter, and so on and so forth. And so we'll take a quick sample case here. An 8-year-old Caucasian male presenting to the ED with facial angioedema since waking up. As you prod, this is the 4th such episode in the last 3 months. The symptoms have resolved, but they can last 3 days. Well, what's the life cycle of a mast cell and histamine-mediated angioedema? Anyone?
Hours.
Yeah, 1 day. Yeah. Usually by 1 day, you're cycling into your next episode. For HAE, you didn't see anything in that C1 inhibitor grid about IgE or histamine. It's kallikrein mediated and bradykinin. So those attacks, they uptick for 2 days if left alone, typically, and then will come down over the course of another 3 days. So an attack can last 5 days easily. Make sense? If you don't intervene. So the kid and the parents deny any associated urticaria. They can't recall any triggers, past medical history, allergic rhinitis, functional abdominal pain, preventing the kid from going to school some days. No medications, doing well, an older brother and sister were asymptomatic, and so on and so forth. So many patients will experience one or more warning signs that an attack is coming, as I mentioned in that previous graph. But realize that an attack could last on the uptick, which is when they're complaining, because they are in the process of swelling. Make sense? After the second day, usually they're still swollen. Let's say the face, they look like they went 3 rounds in a boxing ring, but they'll tell you, I'm better now because the onset of resolution started. And that deflating is actually a passive process through the lymphatics. And there's nothing you can do to speed that up. And it's non-pitting. And then there was something yesterday in the conversation, which I wanted to interject with the fellows. When someone comes into the ED with laryngeal swelling or facial or tongue swelling, the last thing you want to do is cause more local trauma by depressing their tongue. Because now you can speed up those little capillaries and venous vessels and then just really expand on that trauma and cause faster migration towards the larynx. And the interesting part also to me is the frequency, severity, and the location of HAE symptoms can vary between individuals and within the same patient. So 2013 might have been a great year for Len. 2014 hits him with a vengeance. It's almost like, wow, that was a great vintage year, you know, and it could just be the stressors or the hormonal signature of that year for the patient. And that's why it's good to follow up with them every 6 months. Triggers, any kind of inflammatory or stressful hit. The big ones we usually talk about and patients recognize, dental work, right? We even put patients who are not on anything on at least a short-term prophylaxis to not have that dentist freak out, because you get the call immediately from them and the anesthesiologist who know how to intubate better than I do of, ooh, this is a high-risk patient. But it's nonetheless a patient we signed up to treat these people and normalize their quality of life. Barometric changes, pregnancy is a big one, menstruation. So it's good to ask when the attacks are happening and plot them on a calendar. Mental stress, drugs, etc. Early signs, I mentioned some of them, but dysphonia is a big one in a younger kid, for instance. Why is this child grunting and, you know, talking hoarsely to their mom or drooling? Time to, you know, usually it's time to get out the epinephrine, but if they're having an HAE attack, that's not going to do much for them. And then features, oops, to prompt you to investigate this further, really it's these 4 are big ones. Angioedema, non-pruritic, I keep repeating this, non-urticarial, and unresponsive to our armamentarium of antihistamines. The serpiginous rash, okay, and that little girl that you saw in the picture on the right, when I asked to see photos of her childhood, what do you know? She's 9 months old in the tub, in the little tub, getting bathed, and her stomach's poofed out, and there's an erythema marginatum covering it. But it looks like a child who's mottled, right? Newborns, get them out. It's okay. Let me warm them up. Things will get better. Well, when you warm that kid up, you've covered them. You've made the problem look like they went away. And then obviously family history of HAE is a helpful hint, but unexplained abdominal pain is a big one. More than 50% of HAE patients will have recurrent abdominal pains or swelling in their intestines, and a good radiologist will find it on an ultrasound. It's a little tougher to look for, but they're probably sitting in some of these IBS clinics. So if you want to fish some out, I would go start a project there. And then the workup. So when we think of where do these people present when we want them to get their labs drawn, it's in the emergency department. But emergency medicine docs have signed up for the first 5 minutes of every specialty. They're not there for continuity of care, and I don't expect them to have check boxes like a pediatrician or an internist does, you know, talking on rounds and checking off their boxes. So I asked them at least to measure a C4, which should come back in a shift. And you'll see that type 1 HAE is when your level of C1 inhibitor is low. So to explain it to patients, I say, you've got your car, it's called HAE, you're missing a wheel. Is that going to drive well? Nah, it's not going to be a nice ride. The function of that car is low because you don't have enough C1 inhibitor. That'll drive down C4, which is the next complement. So your esterase, the eater upper, inhibitor, don't eat C1, is not there, missing. You're going to eat away your C1 complex, then C4, right? And potentially 2 and 3, which are 2 being minor criterion for lupus. And so you could see how we're moving into the autoimmune world when that happens. type 2, they've got normal numbers. So I'm like, you have 4 wheels on your car, but they're on, who's got a BMW here? You just came back from Germany, Christy. They're running on flat or whatever it's called, super expensive tires, but they're running on flat, so it's low pressure. That's also not going to be a nice ride. So just the function's low. They have enough antigen level. So if the function's low, again, you're going to start chewing up the rest of your complement system. All this to say that if I had one test to look for, and an acquired angioedema, they're going to be low on everything. If I had one test in a desert that I can pick, it would be the C1 esterase inhibitor function. Then you've got, sorry, this is an older slide, type 3, which is now called the normal C1 inhibitor, HAE, which everything's going to look normal there, along with drug-induced or usually ACE inhibitor-induced angioedema that will look normal on labs.
Can we measure bradykinin, or is that just an experimental?
So a couple of centers are getting that now. One's in San Diego, the UC, the HAEA, and then one in DC. So that'll be helpful, but the handling of the sample is going to be tough. Kind of like sending it to Denver with dry ice. I mean, I used to do that a lot to rule out HAE 10 years ago. Out of pocket for the patient, special handling. They're coming in, we're drawing it quickly on dry ice, ship it.
You mean for factor 12?
No, for bradykinin. So bradykinin in the works. I'm talking about more C1 inhibitor function, which had to be sent to Denver National Jewish for the chromogenic assay, which actually looks.
Explain that. I'm not sure.
Sure, and I have slides on. Round of applause for our speaker. I'm joking. I'm kidding. No, but I'm definitely going to bring that up. Now, when you're trying to diagnose this and the patient is on some of these old world treatments like androgens, all right, which we talked about yesterday, we don't know how they actually help produce more C1 inhibitor. Or if they're on C1 inhibitor or fresh frozen plasma, you have to wait a little time for that to wear off to see where the native level of function of that patient is, okay? And so you can see how we have or inaccurate diagnosis of HAE. It's rare, as I said. It can mimic a bunch of other symptoms. And as of just a few years ago, the average time from onset of symptoms, which could be something like scrotal or labial swelling for a 1-year-old, to diagnosis is more than a decade. But to me, the sad part is there's some great grandmas who got mislabeled as peanut allergic in Alabama or Mississippi. For them, that diagnostic period is infinity. They never knew they had the condition. And only maybe close to 2/3 of doctors on a particular survey used complement or C4 to try to diagnose this thing. So I'm going to quickly turn to HAE with normal C1 inhibitor. First described in 2000. So you can see how you're sitting on a cutting edge of a disease here where our cardiovascular colleagues marvel at how quickly in about 13 years we went from a medieval disease with medieval treatment to now something that is pretty well understood and treated. So normal C1 inhibitor has a few mutations that we've kind of taken out and said, I know exactly this to be a mutation that causes normal C1 inhibitor HAE. The rest, sadly, are, I don't know, this is my personal penchant. They're probably neuroendocrine dysfunction patients who present with some angioedema and stomach aches. It's just vague, and they don't have a house yet to put a name to their condition. But you'll see that some of these mutations, especially there's, speaking of Germany, Konrad Bork, an amazing scientist who's identified 2 mutations, plasminogen, kininogen. And usually those swelling bouts in those families are only limited to the oral region, not even laryngeal. So it's tongue or anterior, lip area, etc. But we're understanding more and more about this. And this is where actually the bradykinin femtomolar doctor, I'm blanking on your name, McBride, that you're alluding to will be very helpful. We actually need that to see, to kind of bypass this whole C1 inhibitor only or functional or complement level, because as you saw, there are certain pathways that bypass even kallikrein.
Is there something different about the vasculature in the mouth that makes it more prone to angioedema than some of the others?
So I always like using correlates. Let's take jaundice. I did pediatrics. Anyone know why jaundice starts in the head? And if it's really bad, it'll go to the torso. And if it's really, really bad, you'll see it in the legs.
Never thought about it.
And then it reverts back this way. It's not gravity. The kid can be upside down. The vasculature is deeper as you go lower in the body. So that's why you'll see a lot of facial rashes, heat, all that stuff pop out, because the vasculature is closer to the surface, essentially. That's my first slice at it, physically. Physiologically, it gets even more complicated. Does that make sense? For jaundice and this? Okay. So I'm not going to harp on this, but you could see that some of these mutations essentially just have tongue swelling identified on various attacks. And we've got a better slide for this. Here we go. So the HAEA, the Hereditary Angioedema Association, in 2020 came up with the new guidelines for managing it. And for normal C1 inhibitor, which is a tough one, because who here likes to treat mast cell activation syndrome? Okay, hint, hint. Yeah. So here you've got history of recurrent angioedema, which you should have, in the absence of urticaria, no medications that are going to confound the picture, and a documented normal or near normal complement system. So you have to have that at the outset. Then you have to have at least one of the following: a demonstrated genetic variant of this normal C1 inhibitor, which are 6 genes and unknown as a 7th category. Factor 12 being the earliest one that was identified about a decade ago. But we've got plasminogen, myofurlin, angiopoietin, kininogen, and HS3ST6, which I refuse to spell out. Or a positive family history where they can say, and it's not going to look autosomal dominant, trust me. It's going to run through more females than males, but we have males that have come to the forefront. And that family history needs to be addressed. And then in that patient, you need to work them up with at least a month of high dose. And by that, we mean typically 20 milligrams twice a day of cetirizine, so 40 milligrams equivalent, because that's actually the safety range of cetirizine from the initial studies. Then they brought it down to 10. And you could actually tack on H2 blockers. Some people throw in anti-leukotrienes and even IgE blockade. To just say, I've completely shut down IgE-based, histamine-based productivity or production in this patient. And if they're still having breakthroughs in that month plus, then you're looking at an inclusionary move towards normal C1 inhibitor. And then other supportive, and we don't recommend this, just doing trials of drugs, a bradykinin blockade, but with documented rapid and durable responses, and a predominant visual on imaging. So that's where I'll ask the radiologist, like, can you go back to that ultrasound and really look deep to see if the bowel walls are thickened, which a good radiologist should be able to. All right.
Raffi, I don't know what all those genes do, but
Yeah.
do they all make physiologic sense that they would lead to bradykinin and the same system that we expect in type 1 and type 2?
So correct. And the problem is we don't know the exact bradykinin response on the levels.
But
makes sense.
But those genes have a known function that would make physiologic sense that it could cause this disease.
Yes. Yeah. Without having an effect on the C1 inhibitor level and function. And these are the mutations with their variants. So this is a developing field, and we're talking about just the last 4 or 5 years for the 4 on the right. And so why is the diagnosis elusive, at least laboratory-wise? Not all assays are equal. So what Dr. Altman alluded to is the C1 inhibitor function that you guys send to the local labs, or even probably the university one here, is ELISA-based. And it's actually got a low sensitivity. It's about the low 70s. So it might take 3 hacks at it to bring it up to the 90s, all right, for sensitivity. Which is why I always say after the first one, if you didn't pick it up and you got a high index of suspicion for HAE in that patient, have them be ready with the old slip or a lab order ready to go for when they're having the attack, go get that lab drawn. Because the C4 should be low in that instance. And funny enough, the C4 normal range, we'll say somewhere around 16 or 18 up to the 30s or 40s in many labs. But funny enough, on a peer-to-peer with an insurance doc, who I don't think was a immunologist, you know, I always get the pediatrist or the OBGYN to talk about HAE. That person goes, just tell me that the C4 is below 20 and I'll prove the case, which shows you like how this fluctuates and how these people are attuned to it. Now, the better assay is chromogenic that Dr. Altman alluded to. And chromogenic actually looks at, so I call ELISA-based testing, same with skin testing, like going by the bank and seeing if there's cop cars or SWAT cars with, you know, Raffi written on it. Like they're specifically there for that purpose. But they could be there just withdrawing cash from the ATM, right? So clinical relevance of antibodies. So here, chromogenic actually looks at the shrapnel, or, you know, the crime scene, for lack of, and I hate guns, wars, and all that stuff. But you're looking at C1R and S fragments through the chromogenic assay to say, was there breakdown of this C1 complex? The sensitivity for the chromogenic assay is actually 100%. So if you had to go to it, you know, the problem is it's not readily available and the process is painful. Now, you're trying to diagnose HAE and you're now certain it's not that. What other differentials could there be? Well, autoimmunity, we talked about it. It could just be in the lupus or arthritic world. Thyroid disorders. When I was at Mass General, we had a case that was billed as HAE and then it ended up being SVC syndrome. Okay? Because it's all neck and head swelling. Chylitis granulomatosa and Murchison-Rosenthal syndrome, depending on whether they have neuropathies or not. Trichinosis can actually cause swelling. Gleich syndrome. And then urticarial vasculitis, which with maybe low complements, right? So that's when, hey, it's a rash, but it's leaving a streak behind. Maybe get a biopsy at that point, all right, to clinch it. And here's a little more about that functional C1 inhibitor diagnostics, where you look at the chromogenic assay on the top with a good separation of patient versus controls. And then in the ELISA, done in 2 different labs where it's not as clear cut. Confounding medications. I actually went through the literature to fish out case reports. So don't put too much weight on this, all right? But ACE inhibitors for sure. How about angiotensin receptor 2 blockers? You ever heard about those causing angioedema? Because the old adage was 10% of ACE inhibitor induced angioedema who switch to, hey, put them on ARBs, will have angioedema. Well, with our fellows, we actually looked back at the literature and case reports. It turns out they were still within that 3-month period coming off the ACE inhibitors, and none of them had ARB-based angioedema. So, and it didn't make sense on paper either. We're like, is there a different axis coming in and out of the page that needs to be turned so we can link the 2 systems together? So ARBs should not cause angioedema.
I'm glad to hear you say that because that never made any sense to me.
That's why I'm here for you.
But the but the FDA still makes them label it that way.
Yeah.
Question?
That'll go away, I think.
Yeah.
In the general knowledge base, yeah, soon.
Question. I did have a
NSAIDs, aspirin, we know those can cause their own little AERD, etc. Calcium channel blockers have been described in there. Herbal treatments, garlic, Sanyak, Ecbalium, Elitarium, and then some of the other drugs that are seen there as one-offs. Now, coming back to the 8-year-old with the recurrent bouts of angioedema without urticaria or pruritus, on further questioning, the parents say that he had scrotal swelling in the first year of life. Usually you hear that with a boy like riding his bike the first time, 5 years old, 6 years old. Oh my gosh, Jimmy's privates are going to blow up, right? $1 million workup with nephrology and neurology. But this happened in the first year of life with no trauma. Has missed a few days of school due to severe abdominal pain. And lo and behold, someone finally picks up the labs and sees that C1 inhibitor level is 4, which is pretty rock bottom. Function is low, and C4 level is also almost undetectable. Now, that said, I don't have a slide for this, but there are 2 cases of homozygous HAE, meaning both parents had HAE, and both those people were alive. So it's not a completely fatal mutation where they're cranking out some bit of C1 inhibitor, all right? But just so you know that. But here, this kid looks pretty dry and low on his complement system. And parents are concerned about the increased number of attacks and fear of laryngeal attacks. We're going to send them to school, camp, etc. And so most attacks in kids occur without an obvious trigger, and kids can't even recognize their attack coming on, which makes the pediatric portion of this tougher. And as you know, until recently, we didn't have too many options. I mean, even the HAEA from San Diego, Dr. Rydell and crew, who I trained under, would send me the pediatric cases because they're like, listen, we're adult but trained, and Benadryl under 2, ask your pediatrician, you know. Ooh, me? And so restriction of suspected triggers should be individualized. We want these kids to have a full and normal life. So the whole messaging for this year from the HAE Association is to normalize quality of life. You should lead a normal and healthy kind of life compared to your siblings or peers who don't have this. And so limitations, and how are we doing on time? Okay. Yeah. Limitations because, again, this is an ultra rare disease, but luckily we have the Orphan Disease Act, which starts bringing in credits and all the other stuff that companies can start looking into lower ages and approvals. But it's still a huge unmet area of need. And a lot of pediatricians, as you know, will continue seeing some of their patients since their 20s. When you think of cystic fibrosis, that used to kill people at 2, 3, 4 years of age, and all of a sudden I'm in pediatric, like, what's this 40-year-old doing in room 7, right? It's because no adult pulmonologist knew how to handle CF. And so now as we get this more and more with CMEs and so on, the educational portion, and bringing everyone up to par, hopefully everyone feels comfortable treating the entire age gamut. But we definitely need more studies for novel treatment, and a bunch of them are in the pipeline. So that's kind of more disease state recognition, diagnosis, misdiagnosis. So I'll switch now to the current treatment landscape. And you'll see that for acute therapeutics, and the guidelines say you should have at least 2 doses of acute or on-demand therapy for HAE on hand for a patient, whether or not they're on a prophylactic. And so the first one in the acute therapeutic world is an IV C1 inhibitor on demand. The second one that got approved, which was actually, so it was product 2 and 3 and so on there, was ecallantide, which is a kallikrein inhibitor. It's 12 years of age and older, but it has a 2.7% chance of anaphylaxis. So it has to be administered by a healthcare professional. Icatibant, which is an injection for patients 18 and over, a bradykinin receptor antagonist. And then IVC1 esterase inhibitor recombinant. And this is for adolescent and older patients as a recombinant C1 inhibitor. On the prophylactic side, the bottom portion of your graph there, we have the oral berotralstat, which is indicated for 12 years of age and older as a kallikrein inhibitor. IVC1 esterase inhibitor, plasma-derived, every 3 to 4 days. This was the first drug approved in 2009, I believe. I might have a year or two off. And this is indicated for 6 years of age and older for prophylaxis. Subcutaneous version of this indicated for patients 6 and older, and a monoclonal anti-kallikrein, which is approved now down to age 2. And that's administered every 2 weeks and maybe could be extended to every 4 weeks. And so I mentioned that all patients really, but pediatrics included, need 2 on-demand therapeutics available to them at all times. The plasma-derived IV is the only approved on-demand therapeutic in pediatric HAE. Recombinant can be used at 12 and over. Ecallantide I mentioned, icatibant I mentioned. These are all effective, have a good tolerance and safety profile. But when we think of special cases like abdominal attacks, you may have to actually do a little more than just administer the rescue meds, parenteral fluids, etc., hypovolemia in that peritoneal cavity. And then when we don't have novel therapies approved, we often go to fresh frozen plasma. You'll get that call from an outside hospital. So you could maybe think about solvent detergent plasma if that's available as a secondary line of treatment, really. So I won't go through the first 3 bullet points, but the last one, androgens, were the staple of therapy for prophylaxis in these patients, all right? Anabolic steroids, basically. They come with a big price. And in peds, I sure don't feel comfortable prescribing them, but that used to be the way to go. Or children, childbearing age individuals or potential. And so androgens definitely not recommended prior to Tanner stage 5, and they need careful monitoring. And now we even say get an endocrinologist involved if you're going to switch them off and put them on a more specific therapy so that they're not crashing. And you can see masculinization, hypogonadism in boys, menstrual irregularities in girls, unfavorable other effects, not to mention anxiety, volatile personality changes, and then the reduction in the ultimate body height attainment due to the premature closure of the epiphyseal plates.
So, Raffi, it's interesting that you used the phrase come at a big price.
Uh-huh.
You meant in this case side effects, but we should talk about the price in actual dollars
Sure.
of the new medications in this.
No, definitely.
We'll save a little time for that.
We will. But definitely, androgens, I mean, you don't have to explain someone how to swallow a pill, okay? And there is actually a pill available in the landscape. And the price, probably, I mean, I'm not going to quote prices, but it's low. And it's been around, it's generic at this point.
The androgen price is low.
Correct.
But the new medications to treat this
are higher.
Tremendously
Yes.
higher.
Yeah. Which is why we, don't recommend trial of an on-demand just to see if, your swelling improved and maybe yours didn't. Not the way to go. And to be judicious and do a good workup so that we're not throwing in, my pet peeve, like MCAS, a bunch of normal C1 inhibitor patients that aren't well defined to say, all right, let's give you this treatment without knowing A, for sure, a mutation, or B, that workup that says, all right, I've ruled out allergic or IgE mediated or histaminic angioedema. Because I agree, when we first started in this novel area 12, 13 years ago, you had patients who use an injectable or an IV, they're like, I'm better now. And that's completely subjective. You can block histamine locally with acupuncture. It's in the literature. The minute you take off that needle, the histamine returns. Now, because you're using other efferent, substance P, other pathways to band-aid or change this person's perception of what their swelling, or in the histamine case, in histamine, could be. So, going back to the case, parents are now pleased with the control of swelling attacks. They've screened their other 2 kids who are non-HAE. And then once the kid is placed on prophylactic, he reports this is an actual case. No longer getting stomach aches every month like before, but they still carry, as told, 2 on-demand therapies with the kid. And so patient support is available, obviously, with the products out there, the treatment products, because it's orphan disease, you know, from insurance, copay check, all this stuff that, you know, not my wheel, but has to be done, down to one-on-one patient support, nursing, and all that stuff. But as importantly, the HAEA has a good support system where they can have focus groups, etc., where, hey, I want to see another patient who has HAE and maybe bounce some ideas off of them. Do you suffer, or are you as happy as I am now? That kind of thing. But the trick is to really normalize life as much as possible, educate everyone, the community around the HAE patient, because sometimes the coach might need that. Otherwise, the kid all of a sudden is being pulled from that front line and not playing, not getting any playtime because the coach is misconstruing it as like, I don't want to put this kid in harm's way, to the parents, to the teachers. The HAE patients have potential for receiving human blood products, so make sure they are vaccinated to what we could help block from theoretic or potential transmission. And then, and I'm not trying to raise alarms here, and then all patients should be considered for vaccination, routine vaccinations, and then identify the patients early. So if you find one, start working up the family members too, because that could only help. And other support, like I said, the HAEA, get the patient and us educated on the latest and greatest. Find an HAE expert. For Southern Cal, our clinic is the referral center for the HAEA. School forums, nurse letters, 504 plans, there's scholarships out there, family counseling, genetic counseling. Obviously, I had a conversation with a 14-year-old the other day because he was like, do I pass this on? Because his dad, I was mentioning it yesterday. Do we have time for a quick anecdote?
Sure.
10 minutes. So about 15 years ago, a little further south from me, this was not my patient, in her 60s, called EMS. And when they showed up, she was just plopped down on our dinner table, out. And they tried to revive her, dead on arrival at the ER. Luckily, the youngest EMS, picks up everything on that kitchen table, including a napkin that has 3 letters on there. You can guess what those 3 letters are, HAE. No one's understanding anything. So the ER doc sees the belongings as they're taking the body away. He goes, whoa, whoa, orders an autopsy. 40 pills of androgen in her stomach. So this woman had thought she beat the disease. I'm not having attacks anymore for however many years, and has the androgen tucked away, has an attack, a laryngeal attack, and reaches for that bottle and just downs the whole thing because it's not helping. It's not a prophylactic. So it's complete misinformation, and that, you know, gives me chills. But, and I would always say, you know, that was not too many years ago. And then boom, a month ago, I have a patient that I had seen 4 years ago. He's now 14. Comes in with the mom, and I tried, you know, to the point of like, quit being a stalker, you know, quit calling the parents because we want to get this kid controlled. She brings him in, she's crying. I said, listen, if you're serious, we can continue this conversation. She goes, I'm serious now. His dad passed away last week in jail because the guards thought he was faking an asphyxiation because he wanted to out from that ward. All right. So it's like, and he's got a known HAE mutation that his son has as well. So it's like, it can hit you at any time when you're getting lax and comfortable. So educate the community. Self-administration is possible, including, you know, injectables, oral, and become an HAE advocate and test early.
Since you're telling about specific cases, how did you manage the 8-year-old? Because certain drugs,
Yeah,
most of our drugs aren't approved for HAE.
correct. Well, first, this 8-year-old, actually, my fellow, I think it was for the Quad AI this last year, we put out an abstract. He came to us with 4 swells out of the blue. Grandpa's a physician. He's like, explain to me how this can be HAE out of the blue. All right. So I'm like, we need to test him. And we tested him. What do you know? He's got rock bottom complement system. Dad has nothing. So he's a de novo mutation. So I started them on an on-demand IV C1 esterase inhibitor. They finally got the shipment, and Dad brings them in. They called, like, can we come in and get this administered because we think he's having an attack. All right. Usually he was having peripheral attacks, and he comes in. He's like, he's been moaning, groaning since he woke up, stomach aches. All right. And it's so easy. Hey, I want to look like a superstar. Let's infuse this kid. And he's just not interactive enough for my liking. And I said, any fever, nothing. That's like, nope, you just woke up like this. Then as I'm examining him, and he's just kind of lying there, I felt a lot of moisture in the back of his head. I'm like, this kid's sweating, you know? And I didn't want to press on the stomach again, because you could accelerate even more traumatic-based angioedema. I sent him to UCLA Santa Monica, which is 5 streets away from me. And my fellow was on at the time, and I said, make sure he gets an imaging done. What do you know? It was an API or an HAE attack, chicken and the egg. So they went in, took the diseased appendix out, infused him at the same time, and he did great. And then I put him on the monoclonal against kallikrein, lanadelumab, indicated down to 2 years of age. And so now the parents are happy, and that's the youngest age consideration that we have right now. Yes, Anya.
Any suggestions for if you're trying to school beyond scoping one symptomatic possibility and deciding not perhaps do that? Is there anything else?
Yeah.
So repeat your question. The outside
Oh, sure.
audience didn't hear that.
For all of you on Mars, are any considerations for laryngeal attacks that are subjective, self-reported, where we don't have objective findings? And even for anaphylaxis, I've never bothered to look in someone's throat like ER docs do. I mean, I'm like, how far can you see? Doesn't make sense, like visually with an otoscope. Not really. It's basically just making sure that they have support available in case they really start closing down. I have another patient I consult distantly, actually, whose husband is a hunter. Every time he brings down a deer, which grosses me out, he actually does a trach procedure on the deer. He's like, I got to be ready because my wife, he actually did one on his wife when she was having a throat attack, and she's legitimate HAE. But going back to your question of subjective throat attacks, all you could do in that instance is if the high index of suspicion is there, most of these hospitals have C1 inhibitor on hand, and you could try to infuse and just see. Not so much walk away, or have a nurse at least be there to visually report back to you and say, you know, maybe their hoarseness got better or they stopped drooling, something to hang your hat on. I hope that helps. So in conclusion, diagnosing and treating HAE continues to be not as daunting, but evolving. And the guidelines are getting better and better and help us kind of have parameters. Age-specific indications are available and should be discussed with the HAE specialist. Approved treatments for acute and prophylactic management are expanding, which is great news. And these updated guidelines and treatments and comprehensive care should help us really reduce the unforgivable mortality and a good amount of the morbidity that goes with HAE. Thank you.
There are more and more drugs in the pipeline. We may have even better oral tablet therapy or other things that small biotech companies are doing.
Yeah. I mean, the distant horizon is gene therapy, but you know, it remains to be seen how that pans out with rejection, etc., intolerance and tolerability. But in the shorter term, yes, you've got on-demand oral formulations that we're doing clinical trials for that absorb fairly fast, because you're thinking, an oral formulation for someone who might have an abdominal attack, like how's that going to work? But when you see the PK/PD data, it's pretty fast. One of them, I believe, is the European regulatory body that had them go back and not redesign, but kind of change the study design a little bit. But those are very promising. And then we've got oligonucleotide-based intervention. So we've got a YTE-based monoclonal. You guys know the technology on YTE? So it's viral vector induced to essentially prevent the degradation and digestion of these monoclonals. So that's slated to be somewhere around every 3 months to every 6 months as a injection or administration. And there's the factor 12 monoclonal, anti-factor 12, that is meant to be given every month to perhaps with the oligonucleotide as far out as every 2 months. So there's a lot of data that's probably going to come at us in the next year to 2 years. That's exciting. And what we're doing is helping reduce the burden of treatment in that case.
You mentioned thinking that some cases are neuroendocrine related. Can you elaborate on that?
So what I'm talking about is, sure, I mentioned that some cases were neuroendocrine related. What I said was, in the normal C1 inhibitor group, we're not certain of, I would say, I will personally say, of at least 50% of those patients that I have that I follow, I'm not certain about what they have. I don't have a name for their condition. So if I find the mutation, great. Now they're for sure normal C1 inhibitor with a known mutation. That makes me comfortable. Now I have a pathway. But for the rest, it's ruling out IgE mediated or histamine mediated with probably a family history. So great, they fulfill the kind of subjective rule out criteria of the HAEA guideline consensus guidelines. But for the other half, and I'm speaking for myself, I don't have anything to go on other than they keep saying I'm having attacks. Look at this picture, I'm poofing out, you know, almost like a gluten bloating person, but it's not based on I ate anything or, you know, that I could say, well, go take a trip to France and eat better, blah, blah, blah. You know, it.
Yeah, are you partnering with
No. Neurologist, yes. But I also don't want all these people to start on ketamine drips and all that stuff. You know what I mean? Because it seems to be curing everything according to them. That's why I call it some sort of neuroendocrine axis is going wrong. I mean, once in a blue moon, you might find PCOS. Great, you're better. Go hang with your endocrinologist or endogyne specialist. But we need to define this group a little better. And they all come in different flavors of I'm swelling. And they read something that closely matches their symptomatology, which is HAE. Sometimes it's MCAS, right? And then other times it's you're going down the foxhole of POTS, EDS, and that kind of the quadrifecta.
Any other questions for Raffi before we let him go?
Can I ask a question?
Thanks again for coming to town.
Thank you, guys.
Educating us and